Now, there are a couple definitions or a couple terms I want to familiarize you with if you don't know what they mean already. Paramnemonic effusion is defined as pleural effusion associated with pneumonia. Stage 1 paramnemonic effusion means simple paramnemonic effusion. Stage 2 paramnemonic effusion is a complicated effusion or empyema. The terms are synonymous, stage 2 and complicated or empyema. And stage 3 is organization of the paramnemonic effusion or pleural peel. And in a given patient who has a pleural infection secondary to a pneumonia, it can progress through these stages, or it may only get to one stage or may stop or whatever. Progression between stages does not always occur. Now, to some extent, these have different appearances. Simple paramnemonic effusion, or stage 1, is paramnemonic effusion, first of all, is present in about 40% of patients who have a pneumonia. It occurs because of increased permeability of the visceral pleura. The lung is inflamed, the visceral pleura is inflamed, it leaks fluid, and you get a paramnemonic effusion. The effusion is typically small, it's sterile, usually an exudate. Because of pleural leakage, it's going to contain protein, and usually resolves with antibiotic treatment of the pneumonia. Now, as far as what it looks like on CT, you usually see a fluid collection that's crescentic and dependent, i.e. it's free. The effusion is usually small to moderate in size. The parietal pleura may appear normal, and by that I mean invisible, or may be thickened, 50-50. And that's because the effusion is usually an exudate. Remember that if the parietal pleura is invisible, if it's normal, it still can be an exudate. This is a nice example, a patient with bilateral lower lobe pneumonias. There's a left pleural effusion. It's unassociated with pleural thickening. It's dependent and crescentic in shape. It's very likely free. Because I don't see pleural thickening, it may be an exudate or transudate. It certainly could be a paramnemonic effusion. Simple paramnemonic effusion. Empyema, or stage 2 paramnemonic effusion, means that the pleural fluid is infected, and that means either positive smear or culture. Most empyemas are associated with pneumonia, but on occasion you'll see one pop up without any recognized previous lung infection. Increased white count within the fluid, increasing effusion occurs, always an exudate. Fibrin deposition occurs with flocculation. And I should say, in a patient with empyema, you will always see pleural thickening. Now, that's my rule. I'm not sure it's 100%, but it's still my rule. So if I don't see pleural thickening, I'm not going to be diagnosing empyema. CT diagnosis of classic empyema. Well, the effusion is large. It's lenticular in shape, non-dependent in location. Parietal pleural thickening is always present. Split pleura sign may be present, and edema and thickening of extrapleural soft tissues is typical. Now, this is a classic empyema. What we see is a lenticular collection, parietal pleural thickening, the split pleura sign, and that simply means that both visceral and parietal pleural layers are present and they're split apart by the fluid collection. Edema of the extrapleural fat. Notice that that fat outside the parietal pleura is not of fat density, it's not of fat attenuation. It's higher in attenuation because of edema. It is edematous because of the inflammation that's there. Now, there's some caveats in the diagnosis of empyema. That was what we see classically, but we don't always see classic cases. Empyema may mimic simple paramnemonic effusion. It may be crescentic in shape rather than lenticular. It may be dependent in location. And the split pleura sign is absent in half of cases. Even though it's a classic sign, it's not always there. And on the other hand, simple paramnemonic effusion can mimic empyema. It may be lenticular in shape. It may be loculated. And split pleura sign may be seen in 25% of patients with paramnemonic effusion that's not infected. So there's overlap between these two things, and you can't always tell them apart. Here a patient with a pleural effusion on the right side. Empyema versus simple paramnemonic effusion is what we would have to diagnose here. this was an empyema. Notice that we're seeing parietal pleural thickening. The parietal pleural thickening predicts the presence of an exudate. The fluid, I would think, is probably free because it's dependent and dependent and crescentic in shape. I would have to say this is either empyema or perimnemonic effusion. I could not make a distinction here, but as it shows, empyema was present. Now let's expand our pleural thickening rules a little bit based on what we now know. If pleural thickening is visible, the fluid is an exudate and may be an empyema. If no pleural thickening is visible, the fluid may be an exudate or transidate. It is not an empyema. In my book, all empyemas show pleural thickening. These are the rules residents learn after they learn not to be afraid of me, which takes about 2 years. And I encourage that, by the way. I like them to be afraid of me. Okay, so here we have a pleural fluid collection on the right side. What can we conclude about it? Well, there's pleural thickening. Okay, that means that it is an exudate and may be an empyema. And if you recall, that was an empyema. Now, how about on the other side? There's no pleural thickening. I don't see any white line internal to the ribs. That means it's an exudate or transidate, and it's not an empyema. And it was not an empyema clinically. Okay? Those are the rules and the different appearances and how I use them when I interpret a scan. Okay, there's some complications of empyema. One is hydropneumothorax, or in other words, air within a pleural fluid collection. The differential diagnosis of effusion containing air is recent thoracentesis. That's like 80 or 90% of them. Number 2, bronchopleural fistula. In a patient who has pneumonia, infection, lung abscess, whatever, and develops an empyema, you can have connection between the lung and the pleural space. That's going to require chest tube drainage. Number 3 is a gas-forming organism. Now, I've been using this slide for, I don't know how many years, 25 years. I'm not sure I've seen a gas-forming organism yet with air in a pleural fluid collection or gas in a pleural fluid collection. So usually it's thoracentesis or BPF. BPF, communication between bronchi, the lung, in other words, and pleural space. BPF in a patient with empyema requires tube drainage. This is a patient I showed you earlier. We can see parietal pleural thickening. You can see a crescentic fluid collection. There are multiple bubbles within the fluid collection. So based on the parietal pleural thickening and the bubbles, I know this is an exudate and maybe an empyema. It was an empyema. And those bubbles were not due to thoracentesis. This had not been tapped. So this was bronchopleural fistula. Now, this is a case I saw a number of years ago. You can tell the scan's a little bit old school. But this is a patient who has a really good example of bronchopleural fistula, something we don't actually see that much. But here you can see air in the pleural space, and you can see a little fluid posteriorly as well. Then here's a big cavity in the peripheral lung with a big hole in the visceral pleura right here. And then you can follow that back into the bronchus. So here you can actually see the bronchopleural fistula. It's very unusual. We do CTs sometimes to look for a bronchopleural fistula. I'm not sure how many we've actually diagnosed based on seeing a hole, but it's not very frequent. It was TB. Now, this is another complication you can have in patients with an empyema. Notice we're seeing a big fluid collection on the left side, and there's a very nice example here of pleural thickening, indicating that this is an exudate and may be an empyema. But then also notice that some of this fluid is extending into the chest wall, into the posterior chest wall. This is termed empyema necessitatis or empyema necessitans, where a pleural infection involves the chest wall by direct extension. Extension of empyema to involve the chest wall, subcutaneous collections of pus develop. Differential diagnosis. Well, when I was a resident, I learned nocardia and actino is the most common causes of pneumonia involving the chest wall, but in actual fact it's TB. And the case I just showed you was TB, and he actually was brought into the hospital by his wife. This is higher up in his chest, and you can see that big collection anterior to his sternum. He was brought in by his wife, who wasn't actually all that sick. He was brought in because he couldn't drive anymore, couldn't fit behind the steering wheel. And that's an honest-to-God story. And this was drained with little tubes in those pus collections, and he actually did quite well, TB therapy. So empyema necessitatis with TB. Okay, now, if the infection is not adequately treated at the empyema stage, it can move on to the stage of pleural peel. This is organization of the pleural infection, ingrowth of fibroblasts, formation of an inelastic pleural rind. This results in restricted lung function. The pleural rind is squeezing the lung and not letting it expand. It's sometimes called trapped lung by our clinical colleagues. Treated by pleural stripping. You really have to go in and rip out this fibrous bag that's surrounding the lung so that the lung can increase and decrease in volume as you breathe. Uncommon with bacterial pneumonia. You usually think of this as something that would occur after an old empyema, but it's usually a result of old TB, much more frequent than bacterial. CT findings, pleural thickening, which is often smooth, reduction in size of a hemithorax, pleural calcification, thickening of extrapleural fat, again with chronic inflammation, extrapleural fat thickens, and residual effusion may be present and often indicates the presence of chronic infection. And that's just one nice example, a patient with a pleural peel. The hemithorax is reduced in volume because the lung can't expand. You see this thick fibrous rind or bag that's surrounding the lung and preventing it from expanding. Normally there's some collapse in the lung because of that. And these patients can be a little bit short of breath because of this, and again, they would have to be treated with pleural stripping. Okay, let's move to neoplasm. Pleural effusion can be associated with pleural tumor, or in people with neoplasm can be associated with lymphatic obstruction in the mediastinum, or can be associated with lung disease in a patient with lung cancer who gets obstructive pneumonia or something. So the presence of an effusion in someone with cancer is a little bit nonspecific. All malignant effusions are exudates. Not all exudates in cancer patients are malignant. Pleural thickening visible on CT is visible on CT in 30% of malignant effusions, 40% of benign effusions in patients with malignancy. So again, the pleural thickening doesn't help all that much, but may be something you will see in a patient with malignant pleural effusion. Here is a patient with a malignant effusion. You can see pleural thickening along the inner aspect of the chest wall. That predicts an exudate. It does not necessarily indicate this is a malignant effusion. Malignant effusion, this was. Okay, let's expand the pleural thickening and effusion rules. If pleural thickening is visible, the fluid is an exudate. We've decided that. Maybe an empyema, maybe a malignant effusion. If pleural thickening is not visible, the effusion may be an exudate or transidate, is not an empyema, may be a malignant effusion. So presence or absence of pleural thickening doesn't really help in this situation. In a patient with malignancy, presence or absence of pleural thickening does not predict presence or absence of malignancy. Pleural Mets, CT findings. Well, pleural effusion is almost always present in patients who have pleural Mets. Pleural thickening may or may not be seen. Nodular pleural thickening is very suggestive of tumor metastases to the pleura. Caveat is pleural plaques and asbestos exposure can give you focal or nodular pleural thickening. Concentric pleural thickening mimicking malignant mesothelioma is not uncommon in people with metastases. Here's a patient with metastatic adenocarcinoma, big pleural effusion, and you can see nodular pleural thickening. This is a finding that is highly predictive of metastasis and malignancy. When we see that, we're going to diagnose malignant effusion. This is a case I saw not too long ago, a patient with nodular thickening of the pleura peripherally, only a small pleural effusion present, and then extensive nodularity involving the fissures. Here you can see at other levels, nodules within the fissures. This is a finding that goes along with metastases to the pleural space, most often with a primary lung cancer, but with other cancers as well. This is pleural mets with involvement of the fissures, and these are recons showing very nicely these metastases or these nodules of tumor within the pleural space without much in the way of pleural fluid. So a nodular pleural thickening like this involving fissures, think malignancy and think first about lung cancer. Now, a study a number of years ago reviewed findings that you see abnormalities of the pleura that predict the presence of malignancy, and there are really 4 that tend to predict malignancy with a reasonable degree of accuracy. And these are, first of all, circumferential pleural thickening that surrounds the entire lung, nodular pleural thickening, as I have showed you, thickening of the parietal pleura in excess of 1 centimeter, that's really thick and unusual with inflammatory disease, and mediastinal pleural involvement, which really must be there if you're going to have circumferential pleural thickening anyway. But these are the findings, very suggestive of malignancy when you see pleural thickening. Here, a patient with mesothelioma, what do we see? We see pleural thickening that's concentric, it's nodular, and here it's in excess of 1 centimeter. And there's also involvement of the mediastinal pleura because it's concentric. So this is a combination of findings highly predictive of some sort of malignancy. Another example, concentric pleural thickening, nodular, thickening more than 1 centimeter, mediastinal pleura involved. This was not mesothelioma but Mets. So it can look exactly the same in mesothelioma and in Mets. Mesothelioma, in most cases, of course, related to asbestos exposure with a long latency up to 40 years being typical. These are classified histologically as epithelial, sarcomatous, and mixed, and the different cell types can have differing CT appearances. The patients typically present with chest pain, dyspnea, and weight loss. Cytology is not sufficient for diagnosis. A pleural biopsy and often some exotic tests need to be done to make this diagnosis. Distinction from adenocarcinoma may be quite difficult. Local invasion is typical. Hematogenous Mets occur commonly but don't usually cause any problem clinically. It's the local tumor that kills these people, not metastases. Mean survival 1 year, 5-year survival is very, very poor. No very good treatment for mesothelioma. CT findings, nodular pleural thickening. It's basically the findings of pleural malignancy. Concentric pleural involvement. Focal mass is pretty uncommon with this. Reduced volume of a hemithorax. Pleural effusion quite typical, and this may be seen with or without pleural thickening. You may, in a patient with mesothelioma, see pleural effusion with little or no pleural thickening visible. A frozen mediastinum where the mediastinum does not shift to the opposite side despite the presence of big pleural effusion. Involvement of a fissure, very common, and calcification, but that would likely reflect the underlying asbestos exposure rather than the tumor itself. A nice example here, concentric nodular pleural thickening in a patient with mesothelioma. You can see some calcification because of asbestos exposure as well. Nice typical examples. You can see some nodules, I think, extending into the fissure. Here a mesothelioma, again with a similar appearance, concentric, nodular, very thick, and PET here showing how this is involving the entire pleural space, top to bottom, way down into the costophrenic angles, and a very typical appearance. Now, this is a patient with asbestos exposure and calcified pleural plaques, and the fact that we're seeing calcification indicates his exposure was years and years and years ago. But this man developed a new pleural effusion, and that pleural effusion, as I'm looking at it here, is unassociated with any recognizable pleural thickening. But in a patient with asbestos exposure, a new pleural effusion like this, even if you don't see pleural thickening, is very suspicious of mesothelioma and has to be evaluated. And this was mesothelioma without any pleural thickening being seen. Okay, the last tumor, localized fibrous tumor of the pleura. Most of these are benign, occasionally malignant. There's no relation to asbestos exposure. They're usually asymptomatic but can be associated with chest pain, hypoglycemia that goes away if you resect the tumor, and hypertrophic pulmonary misspelled osteoarthropathy in a third of patients. Very common symptoms. 2/3 arrives from the visceral pleura. Some may be on a pedicle and may move around. They may be in a fissure. Effusion is uncommon associated with these. When they're small, they tend to have obtuse angles where they contact the pleural surface. And CT shows enhancement typically, which may be homogeneous or heterogeneous. You can see necrosis, cystic regions, and calcification. And here a nice example of a localized fibrous tumor, very smooth and sharply marginated where it touches the lung. This has obtuse angles, at least on one side. Here a patient with a very large localized fibrous tumor that contains some calcium and some areas of enhancement. These can be quite large, and if you don't suspect that it could be that, you're not going to make the diagnosis. You might be thinking this is something from the liver or big lung mass or something like that, but keep in mind that these localized fibrous tumors do pop up. Now I want to finish with a couple unusual things, but things I have nice examples of. Here's a patient with a calcified something or other that's in contact with the pleural surface in the medial left hemithorax. This is the same patient followed a little bit later. I don't know why he was having CT scans, but he was being followed for something. And there it is not in the same place. It is moved posteriorly. Now the only way it can really do that is if it's in the pleural space. So we're looking at something here calcified in the pleural space. There it is on the sagittal recon sitting posteriorly. This is a thoracolith. It's also called a pleural mouse or fibrin ball. And basically it's a little ball of fibrin that developed when this person had a pleural effusion for some reason, maybe a parapneumonic effusion. He developed a little clot of fibrin. Over years, the effusion went away, the clot calcified and moves around. Something you can see on occasion. Sort of cool. Pleural mouse, fibrin ball, thoracolith. This is a patient who had previous trauma. You can see there's been a splenectomy. The diaphragm doesn't look to be intact. There seems to be a defect in the diaphragm right here. And then we see all these little nodules involving the pleural space on the left side. History of trauma. This is splenosis. These are little bits of spleen that are growing in the left pleural space in this person who had a rupture of the spleen, and here a traumatic defect in the diaphragm. So two causes of a nodular pleural abnormality that are more cool than worrisome. Splenosis. Okay, so pleural thickening and effusion rules. To sum up everything at once, the presence or absence of pleural thickening does not help in the diagnosis of malignancy except if you see nodular, concentric, or more than 1 centimeter of pleural thickening or fissural nodules. With focal or multifocal pleural abnormalities, also consider asbestos exposure, localized fibrous tumor, infection, pleural mouse, or splenosis. You must add those to your differential diagnosis. And remember that thoracentesis is easy. So what you're doing when you read one of these is trying to predict what it might be and help them decide what to do. But all they really need to do is put a needle into the pleural fluid to figure out what it is. But it's nice to be able to tell them what they're likely to find and consider biopsy if necessary.